As a valued NEI podcast listener, get $100 off NEI Fall Congress registration with code POD26. That's POD26. Go to nei.global/fall, FALL, to sign up today.
Welcome to the NEI podcast, PsychopharmaPearls. In these 30-minute episodes, Dr. Andrew Cutler, psychiatrist, psychopharmacologist, and chief medical officer of NEI, sits down with leading experts to share psychopharmacology pearls and practice-ready strategies designed for busy clinicians and the patients they care for.
Hello and welcome to another NEI podcast. This one is in our series called PsychopharmaPearls. And I think we have a very interesting topic today. And with me is my good friend, Dr. Will Sauvé. Will, how are you?
I'm really great, pal. How are you?
Doing good. And I hope to really do some interesting education on this one. Some clinicians, it's funny, are familiar with Kratom. Some are not. So maybe we could just start out with a general, what is Kratom and why should we be concerned about it?
So we can start with its original Latin name to answer the question, what is Kratom? Right. So the full name, and we'll slow down and say it together, Mitragyna speciosa, right? It sounds like you're Harry Potter getting ready to do something with your wand, but that's the full name. It is a tree in the coffee family. So that, a very, very close relative to all our big favorite. It's native to Southeast Asia. It's been used there for centuries. And so Kratom in and of itself is not new. It's been around for a long time, and it does tend to get used by millions of Americans, and most of whom will never, ever mention it unless we, the psychiatrists, know enough to ask. So I'd say that's one of the reasons why this conversation is important.
Yeah, it sure is. I don't know that I've been routinely asking about it specifically, and it is something that is relatively widely available. Where would one find this?
Oh, any gas station, head shop, tobacco shop, that these days, and I think it has a lot of parallels with the kind of the explosion of cannabidiol products all over the place and hemp products and things like that. And you'll tend to see Kratom flying together with most of those things, and it tends to be regarded as natural. And that would be a little clinical pearl, because I discovered, as an anecdote myself in the clinic, routinely asking people the questions that a psychiatrist asks at any point during a normal appointment: do you use any drugs? And people would say no. And then about 3 seconds later, they happen to blurt out the last time that they used marijuana. And I'm like, I thought you said you didn't use drugs. And you realize that for quite a few years now, there are many people, they do not consider any marijuana product to be a drug, or they'll say it's just CBD gummies. So they don't think that's drugs. So you have to learn the vocabulary. I didn't just mean, do you use drugs? I meant, do you use any substances that could kind of fit into these categories? And Kratom, I think, absolutely fits there. Once again, because it's kind of regarded as something that you might buy in the supplement section in some stores, or you might buy in the, impulse buy at the gas station right next to the gum, interestingly. But it tends to live kind of across that whole area.
Yeah, I guess the fact that it is not illegal, it's legal, and especially now marijuana is legal in many states, and it's, quote, natural. So I think you're right. Maybe we have to say, do you use anything recreationally, or some other terminology, I guess?
Yeah. It goes back to when, remember in the old days when you and I were talking about evaluating people for concussion, and really the best way that I ever found was to ask someone how many times they've had their bell rung. It's like, that was maybe one of the colloquialisms that was the most universal, and people kind of know what I'm talking about. I don't know exactly what to ask. Are you using supplements, natural supplements, something that you think is non-prescribed, but some way to describe, what it is that people think they're doing. And legally, like you say legal, and you're right, but Kratom's a little tricky. It's legal-ish, right? So it is banned in a couple states. There was a whole thing a few years ago, and I mean, we'll get into the pharmacology, but Kratom is basically a partial mu agonist. So it has action on the opiate receptor. And several years ago, there was even talk in Congress, that there had been a little bit of a rise of the scourge of Kratom, and Congress was starting to talk about they might ban it. And I think actually the wailing and gnashing of teeth came from an infinite number of ER docs that said you're going to have, you have no idea how many people are going to be withdrawing if you suddenly take it off the shelves. So there's already a little bit of a push-pull there. And then the kind of final point that reminds me of when asked to define Kratom, like coffee, it has a gazillion molecules, right? It's like Kratom is not Kratom. Kratom is more than 40 alkaloids, probably most of which are not well understood. Just like marijuana, right? Marijuana is not just THC and CBD. Marijuana is like a gazillion things. And we only really know about those couple of things. And then coffee, I think coffee is maybe something like 2,000 organic compounds. And all we really ever talk about is the caffeine. Kratom, no exception, 40 alkaloids, but the dominant ones are mitragynine, right? So we call it mitragynine, but then you call it mitragynine. That's the dominant alkaloid. But then there's 7-hydroxymitragynine or 7-OH. And you may have seen that in the news. That's a minor alkaloid in the raw leaf, but it's also mitragynine's active metabolite. There are synthetic versions of 7-OH that have been appearing in the wild. It's been around for a while, but appearing in the wild since 23-24. And some of that is labeled as Kratom. So it's, you could, I guess if you wanted to Barney style it, you would say it's synthetic Kratom, but it's being advertised as Kratom. It's something like 10x more potent on the receptor. It has been recommended for scheduling. So the DEA is talking about making it a Schedule I substance, and it could be very, very dangerous. And people at the gas station might be buying it without 100% knowing what they're getting.
Wow, yeah, that is important. Something just occurred to me. Well, what is the difference between Kratom and bath salts? I'm sorry, I'm pretty ignorant about that.
Oh, totally different universe.
Okay.
and the bath salts are not for your bath, by the way, right? So you buy the bath salts that are next to the Kratom at the gas station. If you put that in your bath, you're going to be very, very disappointed. Bath salts are sometimes a bunch of things, right? But they tend to revolve around the cathinones, and maybe one of the most famous is methylone. So for the purposes of today's conversation, bath salts are generally a stimulant. It can be one of a few different things, or maybe even a mixture. In fact, one version of bath salts is actually chemically very close to khat, KHAT, also a cathinone, that is famously chewed upon by certain kinds of cab drivers. Right? And it's very stimulating. It can also be extremely compulsive. But again, with the bath salts in particular, you don't always know what you're getting. So at 1 out of 10, do not recommend. I think bath salts are, even if you go on the websites where like Arrowhead.com, where the people that use kind of get on there and talk with each other, most of them, they don't really like bath salts very much. And they'll usually say, I wouldn't have used bath salts if I could have gotten my hands on something good. But completely different animal from Kratom. You're right.
Thank you. But available in the same places, it sounds like. So.
Oftentimes, right?
Yeah. All right. How are there ways, of course, we should ask now our patients, but are there ways to have some clues that somebody's maybe abusing this?
Yes. I mean, one of them, the first clue, I would say the thing that I think we both learned in residency, and I hope everyone learned in residency, and if not, they should ask for their money back. But when a patient is having symptoms that you just don't understand, it's like that would be a great one. And I don't know if they used this word when you were in school, but we used to ask sometimes, do you think your patient is bipolar or do they have drug polar? Well, the syndrome that you could see with a lot of substances, and Kratom is no exception, would be this very almost cinema style, decompensating person that is super low energy and super agitated and super high energy and up and down and very volatile, and it's not making sense. Can't figure it out. It's like, that would be a great time to start asking about all drug use, but Kratom would be a good one to pay attention to. And then again, I think learning to ask people, are you, not just are you using drugs, but are you using supplements? Are you using natural remedies? Are you using something that you're getting from the store? To see, if they'll say, well, I did start taking this particular thing. And then now you can, start drilling down. It might be Kratom, or it might be, 7-OH that they didn't even know that they were getting.
Well, now that we're going to get into more detail, you're right, on the pharmacology, but the little you've said so far makes me think that there may be a withdrawal syndrome, an opioid-style withdrawal syndrome. So that would be one thing I might ask, for instance. Is there anything that you use that if you don't take it regularly, you start to feel bad, that kind of thing?
Yep, that would be a really, really good one. And, it's interesting how that doesn't occur to people until you ask them that.
Exactly.
Right. The illustrative story, this goes all the way back to San Diego. I met this delightful young woman who wanted to be evaluated for panic attacks. And it just so happened that she sort of, without me asking, because I wasn't smart enough to ask in the moment, she revealed the fact that she was having panic attacks exactly every 4 hours.
Oh boy.
Then we started talking about the fact that she was taking alprazolam, and it's like, yep, she takes the alprazolam, but then exactly 4 hours later, she has a panic attack. She needs another alprazolam. And I was the first person in the entire universe to say, my dear, you're having withdrawals.
Yeah, I'll bet. The point you're making is important. Look for patterns. Patterns can be really informative here.
Oh, patterns are huge. And you hit the nail right on the head that, again, this is a partial mu agonist. So depending on the use and depending on the dose, you're going to potentially see withdrawal syndromes that are opiate-like, but the severity of the symptoms are going to depend on the dosages people are using and kind of what they're using them for. So that's also important to think about. When people are using the natural leaf, the withdrawals tend to actually not be as severe. I'm not sure that it's even fully understood why, except that maybe the concentrations that they're using, aren't quite so high in the first place. It might also be some of the other 38 alkaloids
exactly
will be mitigating some of the actions of the mitragynine and the 7-OH that was part of it. But one way or another, yes, you can see all the normal things you would see with opiate withdrawal. So, pain and achiness and vomiting, nausea, vomiting, lacrimation, agitation, sweating, and so on and so on. And then if someone was actually using 7-OH, it could just be that much more severe because they were getting something that was that much more potent on the receptor in the first place.
Now, something that I always like to do when I'm screening for substance use is I will ask, what does this do for you? How does this help you? There's lots of different ways people describe that. It helps with anxiety or sleep or gives me energy or focus. What do you think people are looking for here with Kratom?
Oh my God, everything. That's the other problem. So yes, right? What does this do for you? Yes. And I think this is especially because it's a partial agonist. And again, especially with the natural leaf, it might have a little bit more to do with something going on with the other 38 alkaloids that are involved. But low doses tend to be energizing and activating. Now, those of us who've been around have heard this from all kinds of opiate users. Right? So this isn't necessarily unique to Kratom, but Kratom in particular in lower doses tends to act like a different drug. So someone who is using it at a low dose, they might honestly tell you that they feel that Kratom is to help them with depression. And if you're not really versed in the nuance of kind of opiate metabolism, that might strike you as the weirdest thing you ever heard. Like, why would someone be using an opiate, when they feel that they're depressed and they have very little energy? But low doses will do that. Now, the middle dose, so somewhere kind of in the median dosing range, that tends to be a little bit more consistent with what you expect from opiate class drugs. So people might, in the middle dose, be saying that it helps them with some of the pain that they have. There are plenty of chronic pain players that would be reaching for Kratom. They may feel that it's anxiolytic. They may feel it's, helping them calm down. All the things, again, that you kind of want from an opiate. And then at the highest doses, it may very well knock you on your tail. So that, just think right then, a big dose of an opiate is what someone might experience from a rather large dose of kratom.
And I suppose there'd be elements of euphoria along the way here too.
Absolutely. Up
There's
to part where you just go over backwards.
Yeah, of course, overdoing it. There's a long history of opioids for depression. So that's not terribly surprising. And then, alkaloids also can be relatives of cocaine and stimulants. And you mentioned the coffee plant. So it sounds like there might be some of the stimulating effects of the alkaloids as well. So this is a pretty rich pharmacology.
Very. And like most of the things that we do, not well understood, right? Always lives on the table. It's like, it's complicated. It's a symphony. And then don't even get me started about all the cytochrome P450.
I was going to ask that.
We started about the cytochrome P450.
All right. Well, let's do pharmacodynamics, finish that up, and then we'll do pharmacokinetics. So first of all, you mentioned cannabinoids, which is a good analogy here, actually. If you smoke marijuana, there are dozens of cannabinoids, all of which have different pharmacology that we don't fully understand. So we've already talked a little bit about probably, I guess, the primary thing here is the mu-opioid partial agonism. But again, as I mentioned, alkaloids are interesting. They actually can also come from the bark of trees in South America, and they're cousins of cocaine, I mentioned earlier.
Right.
So what other aspects of the pharmacology here do you think are going on?
So they also can touch on alpha-2 adrenergic receptors.
Oh, okay.
Right. That got your attention.
Are they agonists or antagonists there or what?
I would say both. It's kind of both ways, but it tends to be a little bit clonidine-like, which may actually have something to do with the mitigation of the withdrawal. So when you're once again using kratom instead of just the isolated synthetic 7-OH, you might actually be getting a little bit of a clonidine-like alpha-2 adrenergic, so it can mitigate some of that.
Yeah, it's an alpha agonist. There's a long history of clonidine being used for opioid withdrawal. You're right.
Precisely. And then there's some serotonin receptor activity. So that lives in there. I do not believe that it's super strong, but it exists. And then there's some adenosine action, which that I'm saying, well, it's in the coffee family.
Yeah, that makes sense.
It's got some adenosine action, and there is some evidence of dopaminergic signaling. Those would be the main things that you're looking at when you're looking at the natural kratom leaf.
So rich pharmacology. And again, I can see people saying it does different things for them. And of course, my bias is when people are overusing substances that they're kind of self-medicating something. And so there's a lot to choose from here, I guess, if you're self-medicating.
Oh, absolutely. I mean, we've been trying to change our baseline ever since we realized we were humans, right?
Yeah, exactly. Are you looking to stay current in psychopharmacology without falling behind? Well, NEI membership gives you on-demand access to expert-led education, practical clinical tools, and resources you can use right away. From master psychopharmacology content to patient education materials and CME opportunities, it's all in one place. Join thousands of clinicians who rely on NEI to sharpen their skills and improve patient care. Learn more at neiglobal.com. All right, well, let's get into the pharmacokinetics. You mentioned cytochrome P450, and the analogy here again with marijuana is really, really rich because these cannabinoids all have different effects on P450 systems. So what do we know here?
So number one, mitragynine is a potent inhibitor of cytochrome P452D6. Every psychiatrist in the room just threw up a little bit. It's not 2D6. It's also a time-dependent inhibitor of cytochrome P453A. It also touches 2C9 and 1A2, which, but the 2D6 and 3A4, are the biggest ones and the ones we care about the most. in modern times, it just hit me like with this thing being a potent inhibitor, especially at 2D6, then heaven forfend someone happen to be mixing this with their, dextromethorphan Wellbutrin combo that they just got slapped on 2 weeks ago. And there have apparently been documented cases of serotonin syndrome. So that's another risk that, someone's coming to the doctor to try to get treatment for anxiety. And that is 100% one of the reasons why someone might turn to Kratom. So you put them on whatever SSRI you wanted, and then they put Kratom on top of that. And next thing you know, they're not metabolizing. And, we all know what happened next, right?
Yeah, boy, when you talk about 2D63A4 and then you throw in a little C19-1A2, you're talking about the major enzymes that metabolize most medicines in all of medicine.
Yep. So to, once again, break it down Barney style as the Marines taught me to do, I think it would be just fair to say that in a patient actively in psychiatric treatment, Kratom's a grenade on the conference table, right? Like there's almost no drug that we use that isn't going to be messed with, I think, by the P450 profile of Kratom.
Well, this is another important clinical pearl then, Will, because if somebody is taking another medicine and they seem to be having trouble tolerating it, they're having a whole lot of side effects, it could be because the blood level is elevated here beyond what you think it would be.
Precisely. And the smart person would basically be asking about supplements and natural substances and heaven knows what else to try to pick up on the Kratom before they offered a $2,500 genetic test, right? So look at the P450 system.
Well, I don't know if you've ever heard me say this before, but I have something I called the shopping bag trick. And I would ask a patient to fill up a shopping bag with every pill bottle in their house, everything they're taking, including over the counter. I want everything that goes in your mouth, or however you ingest. And you will be surprised. And sometimes they will include their supplements in their over the counters and things like that. And that happened one time. I actually had an issue with a false positive urine drug test for cocaine. And this is where I learned the alkaloid story. This guy had recently started a supplement that had a list of ingredients I couldn't pronounce, and I looked them up, and they were all alkaloids from a bark of a tree in South America, and they were related to cocaine, so it was a false positive. So perhaps that would be a good idea in some way to get them to bring in everything that they're taking, even things you'd be surprised other prescribers are giving them that you don't realize.
Oh, yeah.
Or I've had people that have a bottle of a drug labeled with the generic name, another bottle with the brand name, and they're taking both because they don't know that they're the same thing.
You're right. And when I was in training, it was a shoebox, not a shopping bag, but it was
that's fine.
The same thing. We joked about the shoebox. And your point about, I agree, everything you put in your mouth, right? If I can get the patient to, well, in these days, everything you inject too, right?
Ingest, however. Yeah.
So anything that goes into your body goes in the shoebox or the shopping bag. And going back to the fact that, we can get these things at the gas station, the truck stop, and they're considered legal and they're sort of legal, but not always, which means, can you 100% trust the integrity of the person that put that thing in the little box so that the person at the gas station could sell it to you? And one of the more amusing examples of false positives, this is years ago, and it was on the NEI stage, Andy. So it was a wonderful medical that we can have together. We had been talking about L-methylfolate, which and sort of had was still expensive to get it prescription, but it maybe was kind of busting into the people thinking you can get L-methylfolate over the counter. Somebody asked me if L-methylfolate was somehow cross-reactive with amphetamines. And of course, please tell me what you mean by that. We need a little more context. And someone's child who had been started on a supplement somehow came up positive. I think she was irritable and grinding her teeth. And so somebody thought to actually test her, and the poor thing was coming up positive for amphetamines. And so the question was, can the L-methylfolate supplement make you false positive for amphetamines? My answer was, I think it's more likely that the shady individual that sold you some very, very shady, L-methylfolate actually sold you a bottle of amphetamines. And So how many people, not only are there false positives in their supplements, but how many people are just purchasing, they have no idea what they're purchasing because people are putting all kinds of junk, which also goes back to one of the big, I think this is another fair clinical pearl, concerns about like over-the-counter kratom that people are using because they're hoping to get some kind of opiate related effect. And now they might be buying the 7-OH because they're hoping to get the opiate effect. But in 2026, I think we all know, and if we don't all know, we should all know that pretty much everything is contaminated with fentanyl. And something that is already supposed to be kind of a legal / over-the-counter opiate, well, that's a prime target to contaminate with fentanyl so that you have an even cheaper way of making it seem like it's a better opiate. So there's high risk for people that are getting big doses of 7-OH without meaning to, and maybe a little bit of fentanyl on the side.
Yeah. Yeah. The point is you just don't know what you're getting. These things are not regulated or controlled in any way. So you just don't know. Another question as we get close to the end here, Will, is how should we address getting somebody off of kratom, maybe who's using it regularly, in a safe manner, but also in a way that helps their pharmacology so that they would, be getting whatever they're trying to get, whatever they need.
Right. I can tell you right now that the current recommendations are not super satisfying.
Okay, fair enough.
Well, first of all, it's not easier than treating opiate use disorder, right out of the gate, which we all know is hard enough. Now, the first recommendation, which should always be the first recommendation, is a careful assessment that alludes to exactly what you said, right? Why is the patient using this in the first place? And when we talked about the effects of it, could be for a bunch of reasons. It could be because someone has untreated depression and they're using a low dose because it gives them some energy and gets them going in the morning. It might be for anxiolysis. It might have something to do with chronic pain. So finding the underlying condition and an effective way of treating it in many, many cases, absolutely can help maybe take away the desire. If people are using the natural leaf, the withdrawals tend not to be as bad. We already kind of got into that. There is also some science out there, science suggesting that a lot of people using kratom are fairly functional. So that might also be it makes them harder to find and diagnose because of course they're not complaining because they're reasonably functional. They're not necessarily being driven into the office, but when you do find them, I think that statement also suggests that you don't have to go high and to the right and, insist that, this all has to happen right now. Some kind of inpatient, do the withdrawal and everything. So it might actually be reasonable not only to be looking to address the underlying conditions, but start a process of slowly, moving away from the kratom instead of trying to take it away all at once. All that said, it has also been suggested in the literature, I think especially if someone was either using like a very high dose or they just went straight to 7-OH. So something, very, very potent, the withdrawals can be quite so severe. It's not unreasonable to suggest buprenorphine. We could get on that road too and consider some kind of, medication assisted therapy. Now, the worry that I have about that, again, since we're talking about clinical pearls, and I haven't read this anywhere, so this is just Will Sauvé worrying about something that maybe doesn't need to be worried about. When we are prescribing buprenorphine for opiate use disorder, right, that's one of the few situations where you're kind of in a little bit of a legal situation. It's only approved to be used for opiate use disorder. And maybe depending on how you document, I'm not sure that kratom use disorder covers that. So I would suggest a lot of caution, I think, maybe not a never, but I do think it's really, really important to be very thoughtful before someone took someone using kratom into their, buprenorphine Suboxone treatment program as an opiate use disorder. I'm not 100% convinced that regulators would see it that way. So that's a proceed with caution kind of situation. But pharmacologically, yes, that makes perfect sense. You could absolutely treat it like that.
I suppose a consultation would be in order with someone who knows something about that, in your local state or I would
I
consult with
agree
someone.
completely. Right? That's one of the times that it might be smart to call ahead and ask permission.
Yeah, right. Absolutely. Maybe a smart lawyer or a smart regulatory person, whoever you use for your buprenorphine certification. So I think that makes sense. I really like the notion you said the word effective. What I like to talk to people about is, because my bias is they're self-medicating something, is, I call it efficiency. You've just been treating this inefficiently. It's almost like pharmacologically inefficient, because these drugs usually have short half-lives, So I'm going to give you something that's smoother, it lasts longer, won't get you into trouble other ways, and hopefully address these underlying conditions. That's part of the principle you were saying too. And everybody who's kind of using these things knows, maybe I shouldn't use this. I want to stop, but it's hard. So I'm not there to be judgmental about this. There's no reason to be judgmental, but to help explain it in terms that make sense and might lead to a better outcome. The other thing is total abstinence is sometimes hard with somebody who's using any substance. And I'm a big fan of at least harm reduction or some kind of gradual transition plan. But a lot of it comes down to the old shared decision-making, involving them in the plan here, right?
Well, you're exactly right. Total abstinence, in some ways, it's like, well, the offending substance is no longer a problem. But, someone with an underlying condition, well, that poor patient is just white knuckling it, right? So abstinence can mean that just living with the insomnia, we're living with the anxiety, we're living with the depression, and no other solution when those solutions might be available. I think alcohol is a perfect example, because you said short half-life. It's like there are actually few substances that will make you sleep as well as alcohol, but for only a couple hours. So it isn't the fact that it's alcohol that makes it a problem. It's the fact that it's just not a good way to make somebody sleep, because then they're going to sleep really well for the first couple hours of the night, and then they're basically going to be awake with their eyes closed for the next 6 hours. And then after about a year of that, you're going to have a severely cognitively impaired, sleep-deprived human.
Yeah, and it also messes with sleep architecture and all that too.
Mm-hmm.
So I think that that's really it. We really have addressed a lot of these concerns. The first, I guess, as I wrap up here, I'm thinking, first is to be aware of this and to know to ask for it by name, I guess, even, right? Ask for it by name.
Right.
Or at least ask about, because there are many of these things potentially, as we've talked about, people could be using. So you want to ask about any kind of use of things over the counter and things that you like to use that help you somehow, or things that if you don't use, you feel bad, that kind of thing.
Oh, I agree completely. And that there was a joke about it on Saturday Night Live years ago, right, where someone calls the hotline and I think it's someone pretending to be the president that says, well, tell me what you use. And it's like, what do you mean? It's like, well, did you have poppers or uppers or stones? And those people go through this litany of street names. And it is kind of funny to think of a physician trying to learn all the street names. But honestly, if you don't, then you're going to be caught in this position. We also had a similar thing going on in Virginia, because marijuana was legalized, but in a way that it had to go through these, very limited state dispensaries. And I suddenly found myself covered up with patients who were using Delta 8. And of course, once again, you're stuck in this, what the heck is a Delta 8? Like, I'm all the way back to square one. Like, why do we want to be one number away from Delta 9 THC? This doesn't make sense to me. And at the end of the day, the patient that told me that they were using Delta 8 in a state where you could buy just regular old Delta 9 THC, it's not a problem anymore. Like, well, it's because the Delta 9 THC that came from the state costs about 10 times as much. So I had somebody who was now resorting to like gas station gummies with some kind of Delta 8, which was a whole new thing that I had to learn about in order to find out. It's like, what exactly is this person doing to himself? So it's, once again, you hit the nail right on the head. We do need to learn all those words. You need to learn the slang too, because we have to be able to ask all of our patients, what they're doing and why, not in a judgmental way, but just to understand.
Okay, well, unfortunately, we've come to the end of our time here, but boy, this has been really informative, Will. Thank you so much. And I hope that our audience has taken something from this. Are there any kind of final words you would say as we wrap up?
Oh, good heavens. I can't think of anything that I could add on top of that giant pile of flaming logs. This has been really fun, and I'm really, really delighted that you had me on.
Yeah, great talking to you. I look forward to seeing you again. And thank you for listening. And for more information about all of our educational offerings, including our live meetings, our virtual Saturday morning live meetings, and these podcasts, please go to our website, which is www.neiglobal.com. Thanks for listening.
Thanks for joining us for this episode of the NEI podcast, PsychopharmaPearls. Designed for busy clinicians, these episodes bring you focused insights you can put into practice right away to better care for your patients. Please let us know what you'd like to hear more about by leaving a review. And don't miss an episode. Subscribe today. For more trusted education, visit neiglobal.com.